So it's about septic shock. So when you call it a septic shock, so the patient is having sepsis and they're having low BP, typically a MAP of less than 65 millimeters of mercury, and the patient doesn't respond to initial fluid resuscitation. Typically, the dose that we use is 30 ml per kilogram. If the patient doesn't respond to it, we're going to call it a septic shock. So the MAP still remains less than 65 despite fluid resuscitation. It's called a septic shock. So this patient is, of course, in septic shock, and the first line vasopressor in septic shock is noradrenaline. I used to say in my classes that noradrenaline is a kind of a sarvlogonivarn. You can use it in any type of shock. If you have a patient with low BP, just start norad. It works most of the times. But in cardiogenic shock and septic shock, distributive shock especially, NORAD is going to be the first choice for sure, 100%. Because it's a very good vasopressor. It's a very good inotrope with a little or no beta-2 activation so that your BP doesn't really fall. And after starting NORAD, yes, if the patient still doesn't respond to it properly, then you can probably consider adding vasopressin as a second choice according to Surviving Sepsis campaign. And maybe dopamine can be used as an alternative also to both NORAD as well as vasopressin, but it's not a preferred choice because it can cause severe tachycardia sometimes. And it's arrhythmogenic as well. And if the patient still doesn't respond to the initial vasopressors like NORAD, vasopressin, you have added so much, but patient doesn't respond. Actually, as an empirical choice, you can add hydrocortisone because some of the patients with severe sepsis may have something called as CIRSE. What do you mean by CIRSE? That is critical illness-related corticosteroid insufficiency, which is a relative like cortisol deficiency that can be addressed by adding hydrocortisone. Because adding hydrocortisone in patients with refractory septic shock, despite noradrenaline and vasopressin, might improve the vasopressor inotrope responsiveness. That's why hydrocortisone at a dose of 50 mg QID can be added in patients with refractory septic shock. All right. So the answer for this question is going to be noradrenaline. Look at the data from Survival Sepsis campaign. So what do you mean by septic shock? So initially going to give crystalloids, 30 ml per kilogram. So ideally it's going to be NS or RL. So you're going to remeasure lactate, and if the MAP is less than 65 and if the lactate is more than 2, despite that initial fluid resuscitation, you're going to treat that patient as septic shock. That's in fact the definition of septic shock, and in that case the first line vasopressor is going to be noradrenaline.